Among the gene mutations that have been discovered by sequencing the blast genomes, mutation of FLT3 genes appeared very rapidly as a bad risk mutation. So basically, when there is a mutation in that gene, the leukemic cells have a tendency to proliferate and to not die. So this is really a bad risk mutation. Curiously, the complete remission rate is not so different in patients with FLT3 mutation as compared to patients without FLT3 mutation, but the risk of relapse is very, very higher in patients with the mutation. So it has been one of the first targets to target with inhibition, with molecules that could inhibit the FLT3 kinase. And midostaurin has been one of the first drugs developed for that. And what is expected when using FLT3 inhibitors, and especially midostaurin, is that you can prevent the relapse in these patients. And actually, it works. And it works, it's not black or white or yes or no. I mean, but giving midostaurin in combination with a standard treatment during induction and then during consolidation and then during a maintenance phase allowed to prolong survival of the patients.
So using FLT3 as a target in developmental therapeutics for AML has both good and bad aspects. It's a good aspect in the sense that it's a common mutation. FLT3-ITD occurs in about 25% of AML patients, and FLT3-TKD is in about 10%. They're both activating mutations, which means they're gain-of-function mutations. So if you have a gain-of-function mutation, you can presumably inhibit it. It's probably important in the pathophysiology of AML, so inhibiting it might be advantageous therapeutically, much as inhibiting the activated tyrosine kinase called BCR-ABL is in CML. That's the good part. The bad part is that it's a relatively late hit in the developmental hierarchy of AML. In other words, it may not be a founder mutation. It's not going to be the first mutation that leads a stem cell on from a good path to a bad path and being an AML stem cell. So if it's a late hit, inhibiting it might just pare down the problem back to the original first few hit or hits. So that's one issue. The second issue is that the disease can evolve over time, or more specifically, you can have what's called clonal selection, and you might select for clones that are different than the ones that were present at the time of diagnosis. A good example of that in terms of FLT3 is that you might have a FLT3 mutation at diagnosis, give a FLT3 inhibitor, just give regular chemotherapy, and then boom, the patient relapses with FLT3 wild-type disease, implying that inhibiting the FLT3 is not going to be such great shakes after all. And yes, there are some patients who don't have FLT3 mutations when they're diagnosed, get chemotherapy or some other therapy, and then when they relapse, they have a FLT3 mutation, implying that you missed an opportunity, if that's a good word, to inhibit their FLT3 with an agent that would not be used since they didn't have a FLT3 at diagnosis.
With FLT3 mutation, which is important to consider, is that at diagnosis, when a patient comes with a leukemia, it occurs relatively frequently that FLT3 mutation is not present in all the blast cells, but sometimes only in a subset of the blast cell. So this is called the FLT3 allelic ratio. This is addressed by the measure of FLT3 allelic ratio. So you can have patients with low allelic ratio, meaning that the mutation is present only in a minority of blast cells, and some other patients with high allelic ratio, meaning that the mutation could be present in all the leukemic blast cells. And this is different in terms of prognosis. And this is a matter of debate currently. I mean, how to define really what is a bad risk FLT3 mutation? Does allelic ratio play a role? Probably yes. So this heterogeneity within a single subset of AML, which is AML with FLT3 mutation, is also important to consider. Not to mention the fact that there are several FLT3 mutations. The most common is so-called internal tandem duplications, ITD, but there is others. And the risk associated with these different mutations also could be variable. So what is important is that this suggests, I mean, the fact that the mutation could be present only in a minority of cells suggests that FLT3 mutation is not a driver mutation. It's not present at the beginning in the development of leukemia, but could be a secondary mutation, a passenger mutation that is present then after that can occur in a subclone of the disease. And which is interesting is that when the patient relapses, patient with FLT3 mutation, usually the allelic ratio increase, meaning that the cells with the mutation are the cells with the potency to survive and to then proliferate, a higher potency as compared to the subset of cells without the mutation. So usually at relapse, the importance or the ratio of the mutation is more higher than at diagnosis.